Manipal Hospital, Bangalore, Dr. Harish Hegde from Yenapoya, and Dr. Ashok from Bapuji Hospital to chair the sessions. This session is going to cover a range of complex yet common challenges we face in anesthetizing patients with certain conditions like maybe renal or hepatic compromise, from dialysis and transplantation to MELD scoring and obstructive liver disease. The first speaker for this session is Dr. Kavyashree NG, Professor and Head, Department of Anaesthesiology at Sridevi Institute of Medical Sciences, Tumkur. We welcome Dr. Kavyashree to the stage.
Which is Unfiltered Truth, Managing Dialysis Patients During Non-Renal Surgeries. It's not moving. Or on maintenance intermittent hemodialysis for end-stage renal failure. Hemodialysis is the most common renal replacement therapy which is employed in about 4 million patients worldwide. These patients have higher incidence of perioperative complications such as hypertension, pulmonary edema, bleeding disorders, cardiovascular compromise. And there's also a risk of 50% incidence of ICU mortality in these patients than when compared to the patients without renal impairment. So a thorough pre-anesthetic checkup has to be done with a multidisciplinary approach of an anesthetist, surgeon, nephrologist, and cardiologist to reduce risks and to optimize patients' tolerance. However, the data on best anesthetic management in these types of cases is limited. Preoperative testing has to be done selectively for these patients, which depends on patients' medical status and clinical urgencies. Key indicators to note is renal functions test, electrolyte balances, complete cardiovascular status assessment, and coagulation profile. In case of elective settings, you have to plan for interventions before the surgery to optimize patients and to reduce risk associated with these types of conditions. To detect perioperative disease severity, acute physiologic and chronic health evaluation and sequential organ failure assessment scale can be used with reasonable accuracy. To predict perioperative complications, ASA physical status is used. And end-stage renal disease patients who are undergoing regular dialysis are staged under ASA class 3 high-risk patients. While considering anesthetic risk stratification, specific type of the surgery and also functional status of the patient has to be kept in mind by using Duke Activity Status Index questionnaire and metabolic equivalents. Renal function is essential to maintain fluid and electrolyte balance. They may have impaired concentrating mechanisms, so these patients are unable to cope with the extra renal fluid losses, which could be because of severe dehydration, diarrhea, vomiting, or pyrexia, so they are more prone for hypovolemia and hypotension. Renal impairment, if renal impairment is there, the patient might have multiple metabolic disturbances like hypocalcemia, hypermagnesemia, hyperphosphatemia. However, the most common encountered one is metabolic acidosis, which is because of decreased clearance of protons and decreased regeneration of bicarbonate, along with there is retention of organic anions leading to chronic metabolic acidosis. And there is hyperkalemia because of decreased secretion in distal nephron. This condition is potentiated again by acidosis. For every 0.1 unit decrease in pH, potassium levels raised by 0.5 milliequivalent weights per liter. Upon that, these patients are on beta blockers, potassium sparing diuretics, AC inhibitors, and ARBs, which again increase serum potassium levels. So serum potassium levels less than 5.5 milliequivalent weights per liter is considered safe for elective procedures, less than 6 without ECG changes for emergency procedures. If levels are more than 6 with ECG changes, consider 2 hours dialysis before the surgery along with pharmacological interventions. So these patients end-stage renal patients with dialysis, they are vulnerable to hypervolemia with daily fluid intake has to be restricted to 1 liter. Careful titration of all intravenous fluids used intraoperatively during both rehydration and medical administration should be recorded. And crystalloids are preferred over colloids. Maintenance of patient fluid status is guided by goal-directed fluid therapy by having specific hemodynamic measurements like cardiac output monitoring, stroke volume variation for adequate tissue perfusion without causing fluid overload. On cardiovascular system, it is a hyperdynamic state because of chronic systemic hypertension, anemia, and fluid overload status, leading to congestive cardiac failure and pulmonary edema. Upon that, there is decreased reduced triglyceride clearance, atherosclerosis, and more chances of developing ischemic heart disease. Because of hypocalcemia and hyperphosphatemia, there is increased metastatic calcific valvular depositions leading to various valvular lesions and development of fatal arrhythmias because of hyperkalemia. These patients on dialysis, if the dialysis sessions are inadequate, there is more chance of developing pericarditis and cardiac tamponade, and also they are more prone to develop bacterial endocarditis. If there is hypertension, dialysis also helps in blood pressure management. However, intraoperative acute blood pressure management can be done by using intravenous beta blockers with volume overload status. Vasodilators like NTG can be considered, and those patients with residual urine output, diuretics can be given. Medications like AC inhibitors, ARBs, and diuretics may need to be adjusted or discontinued before the surgery to minimize hemodynamic stability. Mean arterial pressure of 60 to 70 mm of mercury is maintained. On the effects on respiratory system, these dialysis patients show higher plateau pressures because of pulmonary hypertension, pulmonary edema. It is a restrictive ventilatory defect. Causes are multiple, leading to ventilation perfusion mismatch. So a PEEP of 5 to 10 centimeter of water is advisable. Hematological changes are mainly because of decreased renal erythropoietin, and because of frequent dialysis, there is blood loss and frequent blood investigations and nutritional deficiencies. They are more prone for normocytic normochromic anemia, which causes rightward shift of your oxygen dissociation curve. So if there is electively scheduled procedures, consider recombinant erythropoietin. However, it causes hypertension. That should be kept in mind. A target HB of 9.5 gram is maintained. In case of blood transfusion, consider using leukocyte-depleted RBCs. In these renal failure patients, it is not the quantity of the platelet which is impaired, it is the qualitative function is impaired, the adhesion and aggregation. So caution, regional anesthesia has to be performed with utmost care. Sometimes required transfusion of cryoprecipitate at a rate of 0.3 ml per kg. There is gastroparesis, so the decreased gastric emptying which leads to increased aspiration. So adequate NPO status has to be maintained. This dose of PPIs need not be altered, but there is reduced dose of H2 receptor blockers and metoclopramide has to be considered. In case of uremia, there can be bleeding into GIT system as well. Among endocrine, these patients are more prone for hypothermia, so consider using forced air warmers. CRF with diabetes patients, the insulin levels are decreased clearance of insulin levels, so more chance of developing hypoglycemia, so insulin requirement has to be reduced. And glucose levels of less than 180 milligram per deciliter or HbA1c of 7 to 8% is adequate when considering before the surgery. Important thing in these patients is dialysis scheduling. This patient has to receive, continue to receive renal replacement therapy as a continuation of their treatment with frequent biochemical monitoring. Dialysis sessions has to be scheduled one day before the surgery, and surgery has to be planned 4 to 6 hours after the dialysis for the clearance of heparin. However, in case of emergencies or situations where there is high risk of bleeding, dialysis without heparin is considered along with saline flushes. You have to take care to adjust ultrafiltration close to dry weight of the patient because weight more than dry weight, they are more likely to suffer from cardiac complications. If it is less, they experience more profound hypotension with induction of anesthesia. Care of patients with peritoneal dialysis is similar to hemodialysis, where there is preserved internal renal function. Along with that, drug clearance is less compared when compared with hemodialysis. So abdomen has to be drained to empty before intubation and surgery. And in case of emergencies, a bridging session with hemodialysis can be considered. Patients on dialysis, two things have to be kept in mind. One is that aluminum toxicity, which is subacute, progressive, and potentially fatal because of aluminum in the dialysate. And dialysis disequilibrium syndrome, where urea is cleared at a slower rate from vein than blood, leading to osmotic gradient and development of cerebral edema. Vascular access, care of IV fistula has to be done. Before the surgery, patency of the IV fistula has to be checked. The site of the IV fistula has to be adequately padded and protected from pressure points, and avoid BP measurement, arteriovenous line securement on the same side. These patients have difficult vascular access because of multiple HT catheterization and subsequent development of stenosis. So in case of vascular access, dorsal veins are preferred with small caliber IV cannula. PICC lines are also not indicated to preserve these lines for future AV fistula generation. In case of central line, IJV is preferred over subclavian due to the development of stenosis. In case of emergencies, however, venous side of the fistula can be cannulated by experts. Avoid securing radial arterial line for the same reasons. When it comes to dose adjustments, drugs which have decreased clearance, so there is increased metabolites accumulation, and also drugs which are dependent on elimination for renals have increased elimination half-life. Along with that, because of gastroparesis, there is decreased absorption of the drugs. And volume of distribution of drugs depends on protein binding, total body water, and time since last dialysis, and drugs which are dialysable. All these things have to be kept in mind. Protein binding of acidic drugs is decreased because of hypoalbuminemia, and on that, because of chronic metabolic acidosis, the organic ions compete with the drugs for protein binding sites on the albumin, thereby increase free fraction of the drug. Conversely, this alpha-1 acid protein, which binds to basic drugs like opioids, is increased, leading to decreased unbound fraction of the drugs. And hydrophilic drugs, there is increased volume of distribution. So all these points has to be kept in mind and while administering general anesthesia to the patient. These patients are more sensitive for premedication, so dose of the midazolam has to be decreased. Among induction agent, propofol can be used safely, but then it has to be used in a graded manner because of the fear of development of exaggerated hypotension. In case of hemodynamic instability, etomidate can be used safely. Inhalation anesthetics are quite safe. Among that, isoflurane and desflurane can be used because they do not form compound A formation with carbon dioxide absorbents, which is neurotoxic. Muscle relaxant, succinylcholine has to be used carefully in patients with hyperkalemia. In case of RSI, rocuronium can be used with the backup of sugamadex in case needed. And this rocuronium and sugamadex complex is quite stable. It stays in vivo for 7 days and which is dialysable. For atracurium and cisatracurium can be used safely. Among the both, because atracurium has this metabolite londanosine, which is neurotoxic, so cisatracurium can be used safely. Among NDMR, because of hypocalcemia and hypermagnesemia, there is potentiation of their action, so dose has to be decreased by about 30%. Opioids, remifentanil, alfentanil can be used safely, and drugs like fentanyl dose has to be reduced. Among analgesics, paracetamol can be used, and NSAIDs are contraindicated in these patients. While performing regional anesthesia, it is associated with increased risk of epidural hematoma with neuroaxial procedures. As explained earlier, because of uremic platelet dysfunction, it is the qualitative function which is impaired along with the frequent use of antithrombotic medications for dialysis. There is more chance of bleeding. So platelet transfusion might not correct this dysfunction, requiring cryoprecipitate at 1.3 ml per kg. In these situations, hemodialysis decreases the bleeding time and also prevents hemorrhagic complications. So regional anesthesia can be considered safe unless otherwise contraindicated to minimize polypharmacy and which is associated with general anesthesia. Monitoring, apart from ASA standard monitoring, in hemodynamic unstable patients, IBP may be necessary because these patients are less tolerant to hypotension along with frequent ABG to look for metabolic disturbances and electrolyte balances. The dialysis patients with pulmonary hypertension, CVP and pulmonary artery wedge pressure might not be they are of limited value and might not correlate exactly. So goal-directed parameters like cardiac output monitoring, transesophageal echocardiography can be used in hemodynamic unstable patients. In comparison of anesthetic techniques, as already explained, local and regional anesthesia can be considered unless otherwise contraindicated, where GA is associated with moderate to severe physiological disturbances along with cardiovascular instability. Important thing is, when do you want to reschedule the dialysis? Dialysis is scheduled 1 day after the surgical procedure, along with taking care of infection control, multimodal pain management, and early mobilization and incentive spirometry. So managing these types of patients, however, the data is limited and it involves multidisciplinary management, including anesthetist, surgeon, a nephrologist, cardiologist. Whenever possible, less invasive methods, and consider regional or local anesthesia unless otherwise contraindicated. Thank you. Thanks for the opportunity provided.
Thank you, Dr. Kavishri ma'am, for that excellent start to the session.